So early in my academic career, when I was preparing for what became my PhD in aspects of the biology of depression, I was looking at papers reporting on the prevalence of depression. How common is it in different contexts? And I was looking at papers on how common it was in dementia, 35%, 48%. And then I found a paper saying it could in 100% of people with dementia. And then I found another paper which said it occurred in 0% of people with dementia. And of course, that was just due to the slightly artifactual way in which depression was defined. But it illustrated how then, if you vary a definition, you get very different prevalence figures. And in society, you will hear all sorts of figures about how common depression is. And it depends really very much on the definitions that are used and indeed the methods that are used then for assessing depression in the different contexts. There's no doubt depression is a common illness. How common, as I say, varies and is difficult to say, but I'll come back to that later on. But certainly it is a fine example of what I earlier called inflation, disease inflation, that far more people will be reported in all these studies as having depressive illness than actually do have what I at least would say is real depressive illness. And the medical historian Edward Shorter then published a book a couple of years ago called How Everyone Became Depressed. And again, it's an easy and quite amusing read as he reflects on the various pressures in Western societies that have caused this immense inflation in depression then in particular. But the first thing to say then is that depression itself is a pretty bad term.
Contrast is just not good enough. Sorry, I can't.
Can we have the lights down at the front?
Thank you.
Is that okay? I hope so, because there'll be a few of these to read. So Lewis Walpott, when I was studying for my BSc in St Andrews University, then I studied some of his works on embryology. And then I later learned that he was a professor at UCL in London, and he had suffered a severe depression, and he later he published a book called Malignant Sadness, The Anatomy of Depression, and so I include today some quotes from that book. And here then, when he reflects on what a terrible term really depression is for such an awful illness, he says, it deserves a special word of its own that would encapsulate both the pain and the conviction that no remedy will ever come. We could certainly do with a better word for this illness than the one with a mere common connotation of being down. William Styron, as a novelist in the 20th century, he won various prizes for his writings. He wrote books such as The Confessions of Nat Turner and Sophie's Choice, which apparently were very widely read, though I haven't read them myself. But I have read his own account of his experience of depressive illness, Darkness Visible, a memoir of madness. And like Lewis Walpott, then, Styron, as an articulate and intelligent man, was able to kind of give a better description of some of the horrors of depression. Most of the people I meet lack that ability to be able to articulate, to explain how awful their experience actually is. But Styron, like Walpott, really doesn't like the term depression, and neither do I, and we're stuck with it. But he says, Styron, depression is a word that slithered through the language like a slug, leaving little trace of its intrinsic malevolence and preventing by its very insipidity a general awareness of the horrible intensity of disease when out of control. And again, melancholia would appear to be a far more apt and evocative word for the blacker forms of disorder, but it's been usurped by a noun with a bland tonality, lacking any magisterial presence, used indifferently to describe an economic decline or a rut in the ground, a true wimp of a word for such a major illness. And depression is a horrific illness. It's a horrifically disabling illness. So Lewis Walpott, wrote at the beginning of his book how this was the worst experience he had had, worse than watching his wife die of cancer, I'm ashamed to admit that my depression felt worse than her death, but it's true. I was in a state that bears no resemblance to anything I'd experienced before. It wasn't just feeling very low, depressed in the commonly used sense of that word. I was seriously ill. Or styron, the main title, Malignant Sadness, is meant to emphasize the very serious nature of depressive illness and to reflect my conviction that normal sadness is to depression what normal growth is to cancer. In my book, I included this quote from the Puritan author Timothy Rogers, a pastor then in the 17th century, describing his experience. His ministry was crippled, as many of you know, for many years by his repeated episodes of depression. And he reflected on the lack of understanding he experienced from Christian people around him. It's commonly said then by others who don't know what this melancholy is, why do you think so much? Divert yourself, think of something else. But it's no more possible when this disease comes with violence to divert their thoughts, and it's possible for a man with a broken leg or arm to walk and act as he used to do before. They can think of nothing but what they do think of. Just a man with a toothache cannot forbear to think of his pain. Though others urge us to rule our thoughts, it gives us no relief. It only adds to our misery to be frequently urged to do that which we cannot do. I'm not sure that games that we play is the right word, but most of us going through medical school would play this kind of game where as you went through the different departments in the hospital and so on, and you would think, which illness would I not want to have? Which would be the one I would least want to have? And it wasn't cancers. It wasn't heart disease. It would be neurological conditions like Parkinson's disease or motor neuron disease, or mental illnesses like schizophrenia or depression. Because these are holistic. They don't damage part of us. They affect the whole of our being. And that's why they're particularly bad. When I was preparing this talk, actually, I was visiting my GP about a minor problem I have with my eyes. And she commented she had just seen somebody with a severe depression. And she said, it's really the worst of illnesses. As a psychiatrist, of course, you'd say, well, I'm biased. I'm going to say that mental illnesses are the worst, aren't I? But GPs, I think, have perhaps, might say more objective and wider perspective, and that was her view. John Horder was a president of the Royal College of General Practitioners, and he had several illnesses. He had been crippled by a severe heart attack, and he had suffered the excruciating pain of renal colic. But he says, if I had to choose again, I prefer to avoid the pain of depression. It's a surprisingly physical sensation with a surprising resemblance to coronary pain, heart attack, because it too is total. It cannot be relieved quickly. It even threatens life. It is oneself and not one part of one's machinery, a form of total paralysis of desire, hope, capacity to decide what to do, to think, or to feel except pain and misery. In preparing this talk, I know that there will be several people, quite a number of people in this room who will have had depression, and many more who will have had or do have people in your families with depression. And so I didn't begin in the way I've done because I think, but I need to convince you that depression is a real illness. But just to try and give you some idea, especially those of you who haven't had this kind of experience directly or secondhand, that it really is a horrific condition to have. So how medically do we go about diagnosing it? Earlier then in our first session I talked about clinical syndromes and so on. So this is the syndrome by which we define and diagnose depression. 9 core features: sadness, anhedonia, lack of enjoyment, anergia, lack of energy, loss of appetite and weight, insomnia, pessimistic thinking, poor concentration, suicidal thinking, and psychomotor retardation. That means slow down in your movements. And for diagnosis, you need at least 5 of those 9 symptoms. Now, you might look at that list and you might say, ooh, I've got several of those. I don't sleep very well. I feel tired and I feel miserable quite a lot of the time, and so on. And this is one of the reasons, of course, you can get very large figures for how common depression is, because you simply take a list like this. People go out and do surveys where they just ask people, how's your sleep? Oh, not very good, and so on. And you end up with lots of people endorsing, ticking, 5 or more of these. And so you claim that lots of people have depression. And of course, it's more sophisticated. This is a summary. Each of these terms for a psychiatrist is tightly defined as to what you actually mean by the lack of energy that you get in depression and sadness, etc. And so it's not as simple as just sort of ticking the boxes on this list, so that each of these symptoms, when properly used, is much more tightly defined. But more than that, these symptoms, of course, as I said earlier, need to incapacitate you. They need to lead to that loss of function. It's not enough to just, as it were, be able to endorse these symptoms. It has to impact on your daily living. And the symptoms have to be present for at least a couple of weeks, almost all the time, in the definition. This isn't a fleeting experience. So depression then is defined in these ways. But some of the most important, actually, and worst features of depression aren't included in the diagnosis. So psychosis, for example, people with severe depression have delusions and sometimes hallucinations. They're not included in the definition. People with severe depression have horrific agitated, distressingly painful agitated behavior, which is not included in the definition of depression. People with depression have cognitive impairments, memory problems, and so on. Again, it's not part of the definition. Yet these are actually some of the worst features of the illness. So that's just one of these odd ways in which the conditions are defined, and arguably not very well. So depression is defined in this way. So I'm not going to be looking at things which wouldn't fit within that definition, but which you will experience. So of course, we're not talking about normal sadness, which we all have from time to time because we live in a fallen world with all sorts of grim experiences that affect us, and we are creatures with feelings, and we respond to those contexts and to those provocations and so on. So we're not dealing with that. Neither are we dealing with what is called spiritual depression, a term that's probably most associated with Martin Lloyd-Jones's book, which bears that title. And when I read it a long time ago, and I reread it when I was preparing this talk to try and understand what the good doctor was talking about when he referred to spiritual depression. And I found that if you read through the book, he actually uses it in several different ways and not very consistently through the book, sometimes referring it to non-Christians who are feeling guilty for bad behavior, sometimes using it to refer to Christians for the same sorts of reasons, sometimes referring it to Christians who are struggling with life and might be normal sadness, and so on. He used it in different ways. But I'm not talking about those as sort of pastoral church situations that you deal with all the time. This is not depressive illness. And I'm not dealing then with depression that occurs in the context of other sickness. It's, of course, very common for people who have other, particularly severe illnesses, to have aspects, features of depression, and sometimes to actually have depression, depressive illness. But usually they have depressive symptoms, which if you've got, say, Parkinson's disease, it's understandable that you will have some of these other features, and it's almost unavoidable. But that doesn't mean you've also got a depressive illness. You've got Parkinson's disease, and those are aspects of Parkinson's disease, for example. And I'm not going to be dealing with grief either. So people, when we're bereaved, we have some of those same features that are associated with depression. We don't sleep very well. We, of course, feel very sad because of the loss. We don't eat. We lose our appetite. Sometimes we'll lose weight and so on with that. But it's understandable in the context of the reaction then to the loss. Again, some people in that context do develop depressive illness because the loss event, the grief, the reaction to the grief, takes them over that boundary into depression. They do have a depressive illness in that context. It certainly occurs because it's an external event that can impact on you mentally and cause you to be depressed. But grief as such, normal grief, is not what we're talking about. And finally, fifthly, we're not talking about burnout. So burnout isn't depression. Burnout is a common phenomenon in people caused by long hours of work, under lots of pressure, bearing heavy responsibilities. And so I know men in the ministry who have burned out. Burnout happens to men in the ministry. It isn't depression, which isn't to say it isn't a problem. A colleague of mine, consultant colleague with whom I work, he had to take time off work. I don't know about what was happening at home, but there were clearly pressures and problems there. But he was finding the workload in the health service extremely difficult, and he struggled and burned out, broke down, as it were, and had to take time off work. And when he saw his GP said, "Oh, I think you should take this antidepressant." And he said, "No, I'm not depressed. I'm exhausted. I'm burned out." So he knew he needed mental rest and physical rest. He did not need psychotherapy, and he did not need antidepressants. So burnout is not what we're talking about. So these things are problems, and they're pastoral problems that you will encounter, but they're not depression. So what are we going to consider? Well, we're going to look at three types, if you like, or examples of depression: psychotic or severe depression, moderately severe depression, and then psychosomatic or mild depressive illness. Now, all these things are what are sometimes called long-term conditions, because whether depression is mild, moderate, severe, however bad it is characteristically not short-lived. And that's why you had some of those despairing comments in those quotations I gave you a few minutes ago. If you knew that it was like flu and it'd be over in a few days or a week or so, it would be a lot easier to bear. But the problem is it isn't. Depression's never over in a few days. As I said, by definition, it has to last for more than 2 weeks, and typically it lasts for months. And most people won't recover for at least a year or two, if ever. So it's a long-term problem, and one of the, I think, important points in dealing with people with depression is trying to adapt to the fact that it isn't going to go away quickly. So just back then to how common are these? So 0.5% might be the severe or the psychotic depression. But then what's pretty severe, moderate depression, very disabling, stops people working and functioning at home and so on, is much more common, 2 or 3%. And these are actually robust figures. And so although I've talked about inflation of disease and so on, to have, say, 3% of adults at any time with depression, this is common. There are lots of people who have significant, important depressive illness. And then mild depression is much more common. 10-15% would be reasonable figures from research. I would go for probably under 10% myself, but nonetheless, there's a lot of people who have problems with some level of depression, what I've called mild or psychosomatic depression. But then it raises the question of, are these the same thing? So are we dealing with one condition, as it were, here, in which we've got different levels of severity, and you just pass from a continuum from normality through mild, moderate to severe? Or are we talking about different things, different illnesses? Now, my view is we're talking about different illnesses, and that is that's a minority view, I think, in my field. But I would say that the people who have moderate and severe have got a different kind of illness from the people who have mild depression, I think that's demonstrated in practice by the way in which it's treated and dealt with differently in the health service, actually. But that's a whole different area. But it's just so you're aware, is this one thing, one continuum, or not? Is it more than one illness? But severe or psychotic depression is, say, pretty horrendous. And as I said, the GP says it's the worst of illnesses. So this is somebody who suffered from it, quoted by Lewis Walport. That's the thing I want to make clear about depression. It's got nothing to do with normal life. In the course of life, there's sadness and pain and sorrow, all of which in their right time and season, normal. Unpleasant, but normal. But depression is in an altogether different zone because it involves a complete absence. An absence of affect, an absence of feeling, absence of response, absence of interest. The pain you feel in the course of major clinical depression is an attempt on nature's part, nature after all abhors a vacuum, to fill up the empty space. But for all intents and purposes, the deeply depressed are just a walking, talking dead. So one of the difficulties people have in articulating the feelings with severe depression is that they don't have feelings in the normal sense at all. So that's why many of us say it's different from an extension of normal sadness and what's mild depression. There is a profound absence of an ability to experience normal life at all. And that's extremely painful to undergo, to feel kind of detached or cut off from, as it were, the world of the living, to feel, as Wurtzel says, to be one of a walking, talking dead. This profound absence of all the normal experiences that you and I take for granted. So for psychotic depression then, these are people who should see psychiatrists. They should be dealt with in the health service. Most people with this level of depression will end up in hospital, and many of them will end up being sectioned. As I said earlier on, detained under the Mental Health Act. And they are treated in hospital with combinations of antidepressants, often at high doses, and antipsychotic drugs, and with ECT, or electroconvulsive therapy. ECT is easily the best treatment for depression, easily the best treatment, yet very, very underused because it's had such a bad press and is held in high disregard by a lot of lay pressure groups and so on. But it's several times more powerful as an antidepressant than any medication that we have. And for many people, it's life-saving. Because in the past, a lot of people died from this depressive illness. And they died not because they killed themselves, but because they wasted away through not eating and drinking. Because this complete absence of interaction in desire and feeling, they wouldn't eat. And you couldn't get them to eat. And they died. And ECT saves people like that. I mean, today we can put drips and so on in, but people get so profoundly ill that they die with depressive illness. So in the health service, we treat them in this way.
Sorry, Alan, can you just say what does ECT stand for?
Oh, sorry, electroconvulsive, so shock therapy. So you put an electric current through the brain, and it induces an epileptic convulsion, a convulsive seizure. But that, for reasons we don't fully understand, is therapeutic, very therapeutic. And it's actually safer than antidepressants. And there's, we could talk a lot about ECT, but it's just to say it is a very effective treatment. But for you then, how can you help? Okay, so somebody with severe depression, how can you help? Well, please do visit. It's not easy visiting people with severe mental illness. It's hard. Your visits can be short, but do visit. Show them by your visits that you do care for them, that you've not abandoned them. Try and visit frequently. Get other people in the church to visit. Just do the simple things. Talk with them. They might not talk back. They might not respond to you. But do talk, and do talk about what you've been doing, just ordinary things. Pray with them. Read the Bible. Secondly, do ask about suicide. Do ask about suicidal thinking, because everybody who has significant depression, moderate and severe depressive illness, thinks about suicide. They might not tell you about it. They almost certainly won't tell you about it if you don't ask. But they will think about it because it's an indicator of the severity of depression. Once you reach a certain level of depression, you reach a level of despair in which suicidal thinking becomes entirely natural, as it were, and understandable, because it's so horrific. But by asking about them, you're not going to make them think about it. They already do think about it. And you're not going to make them more likely to kill themselves or anything. It'll be the opposite. That's been shown. If you don't ask people, they're more likely to harm themselves. So you ask people, and you show by asking that you've got some understanding of what they're going through. And yes, Christian people, good Christian people, will think about suicide. And probably have actually committed suicide. I don't know that, but I know certainly good Christian people think about suicide when they're severely depressed. And it's understandable. So show you understand by asking. And ask about doubts about their salvation. Ask about worries about their faith, because they're depressed. It's extremely common then to have worries about one's state before the Lord. As a Christian, should I be feeling like this? And ask about guilt and blame, because they will often blame themselves. I must have done some horrible thing. I must have committed some terrible sin to be like this. So ask about these things, because by asking, that itself is very helpful, because you're showing them that you are understanding what they're going through, how horrific it is. So ask about their doubts, ask about guilt, ask about suicide. And encourage them then in their service of the Lord. It's hard, very hard, when they're like this. And they can't concentrate because impairments in concentration are part and parcel of depression. They can't pray as they would like to pray in a sustained way for any length of time. So you say, well, just pray, take a list. We have a list in our church of people and situations to pray about. And you get such a list or draw up such a list with them. And they can pray now for this person and a little later for that situation in little bursts of prayer. Encourage them to take their hymn book and read or just sing a verse to praise the Lord. They might not have the feeling when they're profoundly depressed. They won't have the feeling. But encourage them then to still do that. And encourage them then to get out to your church services. Take them to church. It'll be hard. But they can participate. They can be with the Lord's people. And know and experience that these are people who still love them. And still care for them. And want to help them. And related to do encourage them and support them in getting out in as normal a way as possible to places they like to go and to do things as best they can that they like to do. And all of you can do all of these things, can't you? And all of these things are really important to the person who's suffering with depression. So moderate depression is that several times more common. Some of these people have to go into hospital for more complex antidepressant treatment regimes. But as we move to moderate depression, then some types of psychotherapy become treatments that are used for which is evidence that they help, and particularly cognitive behavioral therapy has easily the best evidence base. You can't use it in people with severe depression. They're too impaired, and it probably wouldn't work anyway, but it helps people with moderate depression and is used in combination with, typically, with antidepressants. And antidepressants then, particularly in this context, are very effective drugs. There's very robust evidence that they are such. There was controversy a couple of months ago. You've probably heard it in the media. Every time there's some new review of antidepressants, it hits the headlines. So there have been tens of thousands of people in hundreds of studies of these drugs which show that they work. There's no doubt these are effective drugs. There's no doubt also that they're very safe drugs. And so we should, we don't worry that people have them. We should support people using these for moderate and severe depressive illnesses. and cognitive behavioral therapy. That's fine. It's a kind of common sense approach to dealing with it. But if you like, a sophistication of common sense. But it's very helpful. And again, the same sorts of things apply. They might now be at home rather than in hospital. That's much more likely. But they can still have exactly the same kinds of concerns about guilt, self-blame, doubts about their faith, and so on. And so do ask them and encourage them and talk with them about these things. You need to do all the same sorts of things. It'll be easier to do these things with people who are less severely depressed, but nonetheless can still be quite hard work. And then mild depression, or what I call psychosomatic depression. So at this level, of which is far more common, antidepressants don't work. Okay, now there's clear evidence that antidepressants do not work in mild depression. There's also clear evidence that antidepressants are mostly prescribed for people with mild depression. Okay, so most of the people who are prescribed antidepressants actually don't need them. And that then confuses people because, of course, they get given them, they don't work, and people say, well, antidepressants don't work. Well, it's because you're giving them to the wrong people. They work in people with moderate severe depressions very well. And that's what the evidence shows. The evidence shows very clearly they don't work in mild depression. But unfortunately, that hasn't stopped them being widely prescribed in that context for all the sorts of reasons I touched on, all the pressures, societal pressures, pressures from family, pressures then on GPs to prescribe these drugs. There was a letter in the British Medical Journal a few years ago from a GP who was a bit peeved by psychiatrists like myself, saying you shouldn't be prescribing these things for people with mild depression. And he wrote in saying, look, I get somebody comes in, and they're depressed. They're mildly depressed. And I think, well, they need cognitive behavioral therapy, but then the NHS says it's going to take 6 months before they can get to see the therapist. So what do? Well, I reach for the prescription pad and I give them the antidepressants. And the patient's happy, the family's happy, and I'm happy. Okay. Now, they're still a drug that doesn't work, but that's the kind of context in which these things happen. So CBT is an effective therapy, and it's effective in moderate and mild depression, and it's much more appropriate than medication then in mild depression. But there are other forms, essentially modifications, like I've called it BAT. It should be called BA because people don't like calling it BAT. You can guess why. So behavioral activation therapy. And behavioral activation therapy is, I think a good example of the kind of wonderful use of jargon. So jargon, of course, meaning where you use a kind of sophisticated term or acronym for something that's actually really obvious. Okay, so management speak is kind of full of jargon, isn't it? So is psychotherapy. It's kind of full of jargon. So behavioral activation, what is it? Well, it means you tell somebody that they need to go to bed at a regular time and get up at a regular time. That they need to be active, doing things through the day, not lounging around, that they need to get out and meet people and take exercise, and that they need then to socialize and meet other people, okay? So it's behavioral activation therapy, okay? So you are now all equipped to be therapists and apply behavioral activation therapy to people with mild depression, because it's jargon. It is not sophisticated. A colleague of mine, when we were at a meeting and there was somebody talking at length about the merits of behavioral activation, and he leaned over to me and he said, this is where you go into their room and you shout, "Get out of bed, you lazy man! Do something!" He didn't say man because he's not a Christian. But he was making this point. This is not rocket science, as they say. This is not sophisticated. It's straightforward. But it doesn't mean that it's not helpful. Okay? It doesn't mean it's not helpful. So I'm not demeaning it. I'm just saying, it's kind of shrouded. So you might think, ooh, this is something quite sophisticated that health services do, whereas in fact it isn't. Now, when we're thinking about mild depression, then, one of the problems, this is where we move into this kind of, so psychosomatic depression or mild depression is where people, experience the slings and arrows of outrageous fortune and struggle as a result. And they may or may not cross that line, that boundary that I was talking about, from normality to depression. But life is tough and they're struggling. And some of these people are vulnerable because of their life experiences, because of the way they were raised, because of damage through childhoods, abuse in childhood perhaps. Now, under varying levels of stress, most of us, perhaps all of us, will finally decompensate and get some form of mental illness. We all have some level of vulnerability. And we all have some level then of strength to resist. But some people, if you like, are constitutionally weaker than others and more vulnerable to psychosomatic depression. But of course, it's not helpful to say, therefore, this sort of depression helps weaklings. And this all, because again, it doesn't just apply to mental illness and to depression. So, if you take a man and, we'll call him Stephen, and he's always having time off with illness. He contracts infections from the children, and he's ill, and he's laid up in bed, and he's not doing his work. But his wife, Anne, she's fine. She gets these infections, nothing happens. She carries on normally. Does that make Stephen a weakling or a hypochondriac or something? We have different immune systems. Genetic variation in our immune systems makes some of us simply more vulnerable, if you like, weaker to certain kinds of illnesses. That's how we are. And there are other aspects of the way we are, physically and mentally, the way we develop, that makes us more vulnerable to illnesses than other people. That's how we are. It's not what we've done. It's not our fault. We simply are. Some people are more vulnerable to illnesses, physical illnesses, or mental illnesses. And more vulnerable people, therefore, are more likely to get these sorts of illnesses. It's not helpful to talk then about them being weaker, although, as I'm saying, at some level, you say, yeah, that's true. But it's because of experiences they've had, it's because of the gene assortment they've got, etc. We're created differently, with different strengths and weaknesses, and that comes out in this kind of way. So if we're stronger and not so prone to being ill in any way, well, that's good for us. We're blessed in that way, aren't we? But it's nothing to boast about, because I didn't make myself stronger. That's how I am. That's how the Lord's made me. So I've talked about behavioral activation. And behavioral activation is quite close to what's also called stepped care. So stepped care, therefore, is the kind of thing that you can apply to people with mild depression, or those who don't cross the boundary into depression, or those, indeed, who have other forms of milder mental illnesses, whether they're eating disorders or anxiety disorders, OCD, whatever. You can apply some of these steps to help people. So supportive relationships, we're created to be in relationships. Isolation, living alone, is not a good position to be in. And so we don't want people to be isolated. That's why I was talking about visiting the person with depression, etc., etc. We need to do these things. We need to make the effort to engage people with their mild depression or whatever other illness it might be. And support them and help them and encourage their friends at church, others in the church family, to engage with them and not to step back from them because they've got a mental illness. We need to help them to do sort of meaningful work, because we're created to work, to be active. There are limitations. If you're ill, you can't do things in the full normal way, but that doesn't mean you can't do some things. And so we support and encourage people to do some things. to get out there and be active. They might not be able to hold down the job that they would normally hold down. They might not be able to take all the responsibilities at church that they would normally take. But you encourage them to do things, and encourage them to do things they enjoy. Particularly, this is called pleasant activity scheduling, by the way. So when you do that and you're doing your behavioral activation, you can say, and we also applied pleasant activity scheduling, because I took her to the park, and she likes, going around the park. So it's a pleasant activity. Okay, I joke, but it's important to do these things. There is jargon associated with them, but it doesn't mean that they're not good things to do. They are good things to do. We want to help people. We want to support them in such activities as best as they can manage, depending on how impaired they are with a depression. And of course, we want people to eat regularly, to eat what would be deemed to be a healthy diet, to exercise. I don't mean crazy super fit levels. I mean proper, just ordinary levels of healthy exercise activity, not being just at home and sitting around and so on. We want people to sleep properly, so we can engage in a sleep hygiene program. So sleep hygiene means that you go to bed at the same time every night. You make sure that the lights are off. You make sure that there's not noise in the room. You make sure nowadays that no electronic devices are taken into the bedroom. Through the day, you don't sleep, you don't catnap. You engage in some healthy exercise through the day. And these things will help you to sleep at night. And you don't drink coffee late in the evening or anything else caffeinated and so on, or alcohol. And now you know how to be a sleep hygienist as well. So you're learning lots of good therapies here this morning. But these things are, as my friend said, they're following the maker's instructions, aren't they, really? These are doing things that people should be doing, and you support them in doing, some of which, because they're ill, they're going to struggle to do. So they need that extra push, that extra help from you, because without that, they might not manage it. But it isn't that difficult. You can do these things. And then finally, part of step care is to deal with substance abuse. So all sorts of drugs, the legal highs, as they're called, and various forms of cannabis. These things are consumed quite widely, and they are bad for people's mental health. Legal substances like nicotine and alcohol are also not good for mental health. And you will have people in your church who use these things. They won't tell you that they use them, but there will probably be people in your church who use some of this stuff. So, you need to try and gently explore that. And if they are, then you want to help them to stop using these harmful substances which will worsen their mental state and their mental illness. We need to be realistic then about, the society we live in and how people behave. So this is stepped care. It's stepped because you can just apply these things one at a time. You don't rush in and apply all 5 at the same time, as it were. You add them in and you try and choose things that, from your knowledge of the person and their situation, is most relevant. If they're obviously sleep disturbed, then you're going to focus on that to start with. If they're obviously got a very disrupted daily rhythm, you will want to try and get the daily routine with work, useful work and pleasant activities in earlier on, and so on. You will look at the individual and what his or her particular problems and therefore needs are. So stepped care. And finally, I touched on the beginning about the impact of depression. Some of you will have it or have had it, and many others will have had people in your family with it. And you know then that mental illness has a wide impact on family, on carers of people and with the illness. And so support from Christian friends, from the church, for the family is important. It isn't just a focus on the individual with the illness. Support for the family is important. Again, it doesn't need to necessarily be a lot. It doesn't need, it's not sophisticated, but to show that you know when you're going to do some simple practical deeds to help them, to spend time with the person who's suffering, to give them a break, give them, a wife and husband, an opportunity to get out together. These sorts of things are very helpful for the family, for the carers of somebody with a mental illness, because these are, as I said, long-term conditions. They're not going to go away in a few days or a few weeks. And so you've got to think long-term, and you've got to work long-term with people. And the church support for the family as well as the sufferer is really important to help them then in the long haul through their mental illness.